Thank you very much to invite me, and thank you to Professor Bensmail. It's a very great pleasure to stay with you. A lot of new idea, new different point of view about the treatment of movement disorder. And now I would like to share with you in the next 20 minutes some ideas related to spasticity treatment and some not exactly completely new knowledge about spasticity, but just a bit different perspective from. We have a very important and complex problem to face, but during more than one presentation and during the last 2 days, we focus on interneurons. I would like to share with you the role of interneurons, and this morning too, when Guillaume present implanted system able to perform stimulation at epidural level, they are working particularly on interneurons more than motor neurons or sensory neurons too. And the other one will be about mechanobiology and genetic and epigenetic of the muscle related to specific exercise that typically we perform during treatment of spasticity before or immediately after botulinum toxin injection. About interneurons, we know that the modulation of the afferent from the muscle at interneuron level change the activity of motor neurons, then change the modulation of the muscular tone. And they are the gatekeeper of the sensory motor pathways. And it is a very complex situation, and we know that we have some specific pool of these interneurons at cervical level and at lumbar level too, able to modulate muscular tone. Then what means this? Means this that it's possible, this is clinical practice, it's possible to perform a non-invasive stimulation of the spinal stimulation, able to change the activity, maybe at interneural level, able to modulate the spasticity. This November 19, now, just 2 days ago, this is a very nice paper from this group from Vienna with a very long experience about this transcutaneous spinal cord stimulation to modulate pre- and postsynaptic inhibition, to modulate the tone of the muscle. And this is possible at lumbar level, putting the electrode in this position between T10 to L1, and by this way you are able to modulate interneuron that modulate lower limb agonist and antagonist muscle activity. And we have some data in patients with implanted system at epidural level, at lumbar level, that demonstrate that you are able to reduce and to modulate muscular tone using this implanted system. But we have, due to implanted system, the possibility to learn that due to this, you change the control of the trunk too. And when you put an electrode outside, just on a lumbar level, you are able to produce some electric changes in this position, able to modulate the activities of the lower limb where you have more activities than you need. That means that this kind of stimulation is a stimulation able to modulate your system and to combine this stimulation plus stretching, plus exercise for selective control, plus injection of botulinum toxin. Then, in this paper, the group from Austria demonstrate that you are able, using this transcutaneous approach, to modulate pre- and postsynaptic inhibition, and due to this, you are able to reduce spasticity. Then, interneurons at lumbar level are a target of neuromodulation using non-invasive stimulation. It's possible to use it clinically. It's possible to use it before and after botulinum toxin to change, using this stimulation, the sensory motor control using this modulation at interneural level. And these are some results from this paper, very nice results, able to demonstrate that you change on the lower limb at in proximal extensor of the muscle, flexor of the muscle, tibialis anterior, soleus. You change the activity depending on stimulation during stretching, to produce clonus, during stimulation of the plantar part of the foot, and during reflexes activities related to global activities of the lower limb. And there are some papers before this one too, able to demonstrate that you're able to change the modulation of the lower limb muscular tone in spinal cord injury, and in multiple sclerosis too, and to have by this way the possibility to improve walking performance, because this transcutaneous spinal cord stimulation is able to modulate muscular tone, and in the same time is a way to improve the ability to control selectively the muscle that you are using during gait. And this is well demonstrated in this paper, where you are able to demonstrate that the motor evoked responses using this transcutaneous electrical stimulation improve after stroke in the lower limb. Then a target interneuron at lumbar level, non-invasive, to facilitate motor control. It's possible to do this in children too, not only in adults, and this is exactly the system. This is Spinix SCONE in US. They perform a clinical trial in CP patients, demonstrating that in CP patients they improve the ability to walk using a non-invasive system like this one. Another way to try to stimulate the spinal cord non-invasive is transspinal direct current stimulation. Is just a bit different from the other one, but this is another way to do this. Then you have two different possibilities: low cost to use in your clinical practice to modulate interneuron at spinal cord level, lumbar level. And what about the upper limb? The upper limb is a very complex movement, and again, you need the interneuronal modulation at cervical level too to control the upper limb. And we know that upper limb is a very complex system to control, more complex than the lower limb, but very recently, Capogrosso, the group of Capogrosso in Pittsburgh, demonstrate that using implanted epidural stimulation at cervical level, they improve the motor control of a stroke patient for the upper limb. That means that spinal cord at cervical level, even if you have a brain lesion, is a target of your treatment to modulate the activity of flexor and extensor muscle. And it's possible to move again from this implanted system, able to control, to transcutaneous stimulation of interneuronal population at cervical level to facilitate the motor control and to reduce spasticity of the upper limb. That means that it's possible to target this kind of interneurons when you are treating spasticity of the upper limb to facilitate modulation of the tone and motor control. And there are a lot of physiopathological reasons to use it, because again, due to this stimulation, you are able to modulate flexor and extensor muscle activity in the right way. And you have a lot of demonstration in terms of neurofunctional anatomical network that you are managing in this way. Then First of all, interneurons. Second one, again, sensory neurons. And sensory neurons, and there is a correlation between evoked potential and spasticity. And due to this modulation at interneuron level and cortical level, it's possible to have a different integration of sensory feedback. It's possible to facilitate force modulation. It's possible to reorganize the network, able to change the experience of the patient in terms of perception of the body, changing the body image and the peripersonal space. And we published 2 years ago a paper focused on chronic stroke survivors, and using neuromuscular electrical stimulation, we change body representation of the muscle. Another target, modulation of the muscular tone and body representation. What about mechanobiology? We discussed just a bit about genetic and epigenetic too, about the muscle. And inside the muscle, we have the extracellular matrix. This is the typical paper that each one of us use when we present this one. And when we discuss about different stiffness related to extracellular matrix, we have to think that it's possible to modeling and remodeling the system using mechanical stress. And mechanical stress, due to mechanobiology, change expression of gene that you have inside the muscle, and particularly focus on another target, titin expression. Titin is a giant protein inside the muscle that change the expression due to mechanical stress. If you stretch, you have genes that produce titin. If you don't stretch, you reduce the number of genes able to produce titin, and then you change elastic properties of the muscle. Relationship with clinical practice. When you have a contracture and spasticity, it's very difficult to stretch. You reduce stretch, you reduce the production of titin, and you change elastic properties of the muscle. When you put a casting after botulinum toxin injection, you start to stretch and to stress this gene, this is gene and epigenetics, to produce more titin. And if you look at the biology of titin, you need 4 weeks to have the peak of production of titin after stretching. And if you stop stretching, you need around 3 or 4 months to reduce again the amount of titin that you have inside the muscle. That means that when you put a casting, why to put a casting for 4 weeks? To reduce the possibility that exactly when the botulinum toxin is working in the best way, you don't have in the same time the mechanical stress able to change the production of titin. In the same time, why to educate patients to perform stretching regularly, to do this? Why to put an orthosis to maintain lengthening of the muscle? Is a genetic and epigenetic reason, is the biology related to the results of exercise. Because it's very important to do this, because titin is something able to have a memory of the contractile history of the muscle. Then maybe one of the reasons, then when repeat injection, may be possible that you perform stretching in the same time, it's possible to prolong the action of botulinum toxin, for example, and to maintain better results and to improve the result injection by reinjection. Then we have elastic properties and sarcomeric status 2 related to this one. Then biology of the system is very important to know what to do until when the intensity, the frequency, and reinjection time may be, and how to program the assessment of the patient and to look if the patient is doing in the right way everything. And finally, about the action of botulinum toxin. We know perfectly that the main action is at presynaptic level. But what about the relationship between botulinum toxin and changes of the muscle? Inside the muscle, when you inject botulinum toxin, and 10 years ago, this paper in Muscle and Nerve demonstrate that you change the biological activities of gene inside the muscle. Then it's not just related to presynaptic block. You change the muscle too. And then try to think the combination between transcutaneous electrical stimulation to modulate interneurons, stretching to increase the amount of tightening, and changes inside the muscle that change the properties of the muscle. And in spasticity, the properties of the muscle are very important to define the level of activity of muscle spinal. For example, inside the rigid muscle start immediately to react. The velocity is one of the components of reaction. It depends on velocity and the elasticity of the muscle. Then means that when you inject botulinum toxin, it's possible to change something related to tightening, but you have a myogenic effect of the botulinum toxin injection, but particularly if you combine botulinum toxin injection and stretching, then mechanobiology plus botulinum toxin activity are able to change the muscle and to change gene expression inside the muscle that you are treating. That means that it's possible to have a very important effect on the muscle. Some years ago, with a group in Milan, we did a very crazy experiment. We inject botulinum toxin in culture of muscle cells, then without any innervation. And we look using transcriptomics if you change transcriptomics of the muscle. And we realized two different things. First of all, that if you inject in muscle cells of normal subject, you don't have the same transcriptomic effect of botulinum toxin compared to injection in spastic muscle that during surgical procedure we cut and we put inside the system. And we realized that by this way, first of all, the reaction of the muscle of spastic patient react to botulinum toxin in a completely different way compared to normal subject. And second one, that you have a myogenic and fibroblastic potentiation related to botulinum toxin injection. Finally, microRNA. This is the Nobel Prize of this year. There are a lot of relationship between microRNA and spasticity because this one is a regulator of skeletal muscle, and we know that this regulation, this is again very recently, just 1 week ago, they are able to demonstrate that microRNA regulate again the muscle in CP patient. Then means that we have a lot of possibility using exercise to produce microRNA able to modulate the muscle biology per se. And this is the final message. When we are treating spasticity, obviously we have to look the central nervous system. When we look the central nervous system, please look interneurons. Please look to modulate interneurons at cervical level for the upper limb, at lumbar level for the lower limb. Try to plan to stress the muscle per se to change the biology of the muscle using these epigenetic possibilities that we have. And finally, try to perform exercise, because microRNA is related to neuroinflammation too. You have specific microRNA related to neuroinflammation that change after exercise. Then this multimodal approach, electrical stimulation, injection of a drug, stretching, and exercise, is a key point to maintain under control a very complex system that we try to modulate using different approach, using surgical procedure too, but in the same time, we have to combine more than one treatment to be able to reach the goal to treat our patient. Thank you very much for your attention.
Thank you very much, Franco. Maybe do we have a few questions? Est-ce qu'on a des questions pour Franco Molteni tant qu'il est là? Pas de questions? Thank you.
Moi j'ai une...
Pardon.
Philippe. This is the dream.
You have cited the works of Richard Lieber from 2003, but as you have seen yesterday when I have presented, you have a little bit changed, because on the titin, particularly in cerebral palsy, because it's a model of Lieber, you haven't a proof that titin is included in the extracellular stiffness in muscle spasticity. Is not so clear. There is not really so much difference from control and spastic subject in this works. At the contrary, at the beginning in 2003. What is your opinion in this case?
As usual, you have to check. When I looked at the last paper of Lieber, it depends. First of all, CP patients maybe that are a different population compared to, because you have some problem related to the central nervous system that is growing. Then it's very difficult to translate the information that we have in CP patient for adults, first of all. And second one is depend on the muscle that you are looking, because typically they try to look something, flexor of the flexor naris carpi, flexor digitorum, maybe different the situation if you look other muscle of the lower limb, particularly triceps surae. Then it's a very complex situation. It's a typical condition there. We need more than the knowledge that we have now.
Thank you so much, Franco.